Welcome back to the PFC podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC podcast. This is Dennis, and this episode was recorded with the sponsorship and support of the Special Operations Medical Association. Thank you guys very much, and I hope you enjoyed the talk.
All right, so good afternoon, everyone. Thank you so much for having us here. My name is Captain Chase Donnell, former 18 Delta from 5th Group, current second year emergency medicine resident at Hemorrhagic Army Medical Center. Today we'll be talking about blood. Specifically, we'll be talking about cold blood, aka cold stored O-type, low titer donor blood, as it pertains to our cold blood protocol for medical support in soft training events in CONUS. Standard disclosure slide. Views expressed here are our own opinions, not reflective of Department of Defense or Army. Also worth pointing out that he will be talking about some trade names and brand names throughout this discussion, but we don't have any financial or commercial relationships to disclose today. And so hemorrhage is the leading cause of death, preventable death on the battlefield. I really like this phrase. It's at the top of the damage control resuscitation CPG. When I hear it, it almost creates like a gut response, like telling someone who's graduated high school, mitochondria is the powerhouse of the cell. It's just something that we all have heard so much, and we know that it's pretty much an undeniable fact at this point. It's totally ingrained in us from pretty much day one of our medical military training, and how serious we take it is reflected heavily in our doctrine. Like I said, this is in CPGs. That's why massive hemorrhage is first in our March algorithm. Really, if you're training in innovation, our organization is constantly trying to push the number of preventable deaths closer and closer to zero. And this constant striving towards the best possible outcomes is why we've seen whole blood emerge as the superior resuscitation fluid when it comes to treating hemorrhagic shock in both civilian and military circles. Which I like. It's always nice when science kind of lines up with common sense. If they lose blood, then they probably need blood. So we know it's important, but we also know when to give it. These are the indications for pre-hospital whole blood transfusion. They probably look pretty familiar to most people in this room. As a review, T-TRIC says the indication is signs of hemorrhagic shock, which makes sense. They go on to define it a little bit more as altered mental status in the absence of brain injury and or weak or absent radial pulse. And this is the traumatic patient. So Ranger Handbook, Ranger Medic Handbook goes on a little bit further to spell out some additional risk factors that are going to be highly suggestive of hemorrhagic shock, to include one or more amputations, blunt or penetrating trauma to the chest, abdomen, pelvis, pelvic fracture, or vital sign abnormalities, specifically hypertension, tachycardia are two of the base components you'll see pre-hospital, the systolic blood pressure below 100 or tachycardia above 100. So when it comes to whole blood, we're pretty solid on the knowledge. We know it's important. We know when to give it, like I said. But then the next main barrier becomes having it available when you need it, aka logistics. And we'll get into that a little bit more throughout the rest of the presentation. Cool. So all things considered, we do an okay job of making blood available while deployed. But when it comes to blood availability during CONUS training, there tends to be not too much guidance on when to carry it, how to get it, when to use it. And that has resulted in very few units actually carrying whole blood with them to training events. Like the 160th will carry it once in a while on like search and rescue missions that Dr. Radloff will talk about a little bit more. But overall, we don't see units carrying it often, and when they do, it's often done incorrectly because it's not FDA approved. And all this is despite data suggesting that accidents are still among the leading causes of death in non-deployed service members. Of course, we do have access to whole blood while CONUS through existing military and civilian medical infrastructure, which would probably be good enough for most training accidents, but not all, as we'll get into. Many training events might take you outside, several hours away from the nearest hospital, and it just wouldn't be feasible to rely on. So we asked ourselves the question, would carrying whole blood more often while conus have the potential to save lives? We think yes. It probably won't be hundreds or thousands of lives, but it could be definitely life-saving in the right scenario. That's because training accidents requiring blood are rare, but certainly not unheard of. And speaking of training accidents requiring blood, we do have a bit of a plug for an upcoming lecture by Dr. Radloff and Dr. Leonard. It'll be at 1700 in this room, talking through a training accident that did have a delayed collapse and required quite a bit of blood. So I won't spoil anything about the case, but it'll be pretty interesting if you guys want to join us for that. If you missed the presentation, then there will also be a case report poster at 1830 to 1930 that you can check out as well with Dr. Radloff and Dr. Leonard. And since we're talking about blood, I also wanted to touch on Rollo a little bit. Rollo has definitely dominated the discussion on point of injury blood transfusion for the last decade. And for good reason. It showed real-world success. It saved real lives on the battlefield. But as we heard in the prior lecture, it has its place, but it also has its limitations too. It is taught heavily in SOCM, SOCMIS, and at USIS as well, Gunpowder and Bushmaster. But it's worth noting that it's not first line in any published guidelines, and that's because the blood that you get from a walking blood bank is not going to be FDA approved because it hasn't gone through the testing required to get that approval. You can certainly do screening for low titers and things like that, but not going to be FDA approved. So ultimately, we view it as a great tool to have in your toolbox for when the scenario arises that you'll need it, but it's certainly not to be thought of as a silver bullet solution for all point of injury blood delivery. And additionally, walking blood banks become less and less feasible the smaller an operational unit becomes. So if you're doing Ranger operations, you have a company or platoon size element, probably manageable, but as you get down to a 12-man ODA or even smaller into split team ops, then walking blood bank is probably not going to be as feasible, especially like they talked about in the last lecture, all the kind of logistics and time intensity that it takes to actually execute. With that, I'll turn it over to Sergeant First Class Ninchik.
Good afternoon. As we see training scars. So we've already talked about Rollo. We've talked about walking blood banks. We know these are things that any medic across the field can do. 18 Deltas are fully capable of. But we always have these discussions in team rooms and in battalion meds and offices of how would an ODA actually conduct a walking blood bank or a Rollo? We can't. We're trained, we're proficient in it, but we can't do it. There's not enough people. We're too far out. It's not going to happen. So this kind of turned into this team room discussion of, well, how do we fix that? Honey, pretty much resulted in us taking 3 units of blood off ourselves, throwing it in a cooler in the office, and seeing, can we supply our guys with blood? That was the main purpose. I wanted my medics to be able to go out with blood. Now, with this idea came some other training scars. Do we all know the temperature range that blood's supposed to be kept at any given time? Do we know how long it can stay out in your room before it goes bad? Do we know the shelf life of blood? I ask these questions to my medics all the time. Excuse me. So, as you can see, it's literally based on the citrate. It's not just the blood. You have a 21 to 35 day window depending on the citrate that's in the bag, which is why we did a 21-day test on how this would actually operate. Again, your storage temperature is 1 to 6 degrees Celsius. That can be accomplished in almost anything. We did it with a laboratory-grade refrigerator that I happen to have on the property books. And then we were lucky enough to have an APRU that could store the blood as well. Again, 30 minutes at room temp, you're pretty much done with that. And also less than 4 hours, less than 10 degrees Celsius, it can be returned back into storage or in transport as we had it currently. Again, some of these storage containers we used, and these aren't a plug, but like golden hour boxes, golden minute containers, the Safeguard tactical blood box, the nesting units, or the APRE. These are all things we just had and decided to use. More administration of blood product. Again, most of us have been through SOCMIS, SOCMC, refresher, whatever you want to call it. And I take my blood, I put it in a bag, I give it to a guy, and we're done. Well, how do we actually do that forward in a different AO with with fluid warmers that may or may not work, or we don't have the funds to buy them, or they're old because we've got thermal angels, or my quantum battery died, or I don't have the $5,000 to get extra tuning, or maybe it's battalion meds the only option. So it's presenting these options for my guys so they can actually go out and train with it. The other joy of this is I'm putting the onus on the medic. If they want blood, they've got to show me that they can actually do this. Because again, it's a forcing function. If I give these guys blood, they have to know how to administer this blood.
Wrong button.
So, what was our purpose in all this? Kind of like I said before, I wanted blood in the hands of my medics. And just like we talked about training accident earlier, that's where this stemmed from. It was like, why didn't we have blood out at some training site and we do all this high-risk training? It just didn't make sense. Same thing, we wanted to facilitate methods of blood procurement so people can actually go do this themselves. We don't want it to just be us. We want to spread this across the force so other people have the option to get blood at point of injury during CONUS training. As we can see, to prove that we could actually do this on a battalion level, we tried to be as systematic as possible. So as you can see the chart right here, we've got blue, gray, and orange, which represent the 3 bags that we actually pulled off of myself, Dr. Radloff, and another person on staff to facilitate this whole idea of cold stored blood at a battalion level. You'll notice one of them kind of disappears. That was what we considered our go bag. The go bag and the one with the orange line stayed within the low lab grade refrigerator, and then the other one stayed in the EP area, which is the one you'll see in gray over here. That's at a constant temperature. It never left it stayed in there, and it was just, again, our control to prove that we could do this. The one unit that went out, thankfully we had a cephalic going on concurrently with this, so we had a medic that came in, vetted, talked, gave him our questionnaire, gave him the blood, and he took it out to cephalic for a day, would return it, sign it back in, and then over the course of 4 days, did it again. That bag was monitored every hour on the hour with a lab thermometer in the bag so we could actually make sure we weren't going out of range. And as you can see by the chart, we stayed within that 1 to 6 degrees Celsius mark, once again proving that we're fully capable of taking this blood out to training environments and actually being able to use it if need be. At no point did we mishandle any blood. We didn't have any blood come out of temperature range. We demonstrated the fact that this small team room discussion is totally feasible. And it's not just us. Anybody can do this. I literally had a harder time doing my DTS to get here than I did actually getting blood within 2nd Battalion. So this is just, again, one step closer to us facilitating better care for our patients, making sure our medics are doing the right job and providing the tools so they can do the right job, but at the same time also vetting them and making sure they know what they're doing. With that, I'll be followed by Captain Radloff.
Sir. Hey.
Hey, I'm Ken Radloff. I apologize. I am a repeat offender. I've been to SOMA. I was an 18 Delta in a past life and am now an emergency physician who fooled first group into taking me. But so just to sort of discuss what led us to this point, which is what most of the talk is going to be about, there was this patient that Dr. Lennon and I will talk about that required a ton of blood, and he and I are sitting in battalion med going like, why don't we have blood at point of injury in CONUS? And so this study, we sort of took blood off of me, Justin, and another guy and put it in the cooler just to prove to me that I could keep blood cold for a month, which we can. And also because I kind of knew that when I got to the blood lab at Madigan, which is the MTF where we're at first group, that they were going to ask us some questions about it. So after we did this, we went to the blood lab at Madigan. They were great. They were super welcoming. They gave us a whole tour of the facility, and then they busted out the 7 binders of regulations that go with blood storage. So blood storage is FDA regulated. It's also regulated by the Center for Biologics and Evaluation Research, that for CBERG, and it's covered by the CFR, the Code for Federal Regulations. And blood storage facilities are subject to biannual inspections by 3 federal organizations. They require like a full backup generator and a lab tech on site. And so while I knew there were going to be some restrictions here, I had no idea how difficult it would be to actually store blood. And so after having talked with the folks
at the Madigan Blood Lab, it became very apparent that like there's not going to be a combat arms unit in CONUS that's capable of storing blood in the doctrinal sense. Madigan, like most MTFs, does have what they call a soft contingency shelf. And at Madigan, this soft contingency shelf is 4 units of low titer O blood that's kept cold and is available, and Dr. Donnell talked about it a little bit, is available for any soft unit in theory, but not really for training. It's meant for blowouts, it's meant for the 160th on medevacs, and is in practice really only used by the 160th. Additionally, because storage is so complicated, this 4 units, when it goes out, can't be checked back in. It's gone. So it's not practical for what we were talking about using it for as an SF battalion, using it for IRIS training, because every time, twice a week, I would check out 4 units and throw them away. So that didn't answer the question for us. That did lead us to sitting down with the chief of the Department of Pathology and Area Laboratory Services. That's what DPALS is up there at Madigan. Fantastic guy, super soft, supportive, and dedicated to improving the lethality of combat arms units at Madigan. And after discussing with him what possible options were, he linked us up with the Armed Services Blood Bank Center, PMW, which is located at JBLM. We're fortunate that we had them there. And in sitting down with them, for me, I've been in the Army 25 years, was pretty ignorant to what they actually do. I kind of thought that these guys do the blood draws and they go to the hospital. That's not right. It is kind of right. Their primary mission is to get low titer O blood to the combatant commands. And that's what they are here to do. As it turns out, not everybody is low titer O. And so these other types fill up the MTF. But that's not their primary objective. And then so having had the chance to sit down with these guys and talk about what their mission is and talk about what we want to support our mission, we were able to come up with a plan that ideally would answer both of our goals and support both Second Battalion First Group and the ASBBC. And we came up with this pilot program. So the pilot program was not established with an end date. And it essentially had 2 asks. And the ask on our part was based on kind of the math that Justin and I did. We would need about 6 units a month to support our high-risk training or moderate risk training that is greater than 30 minutes from definitive care. And because storage is such a complex thing, and because storage doctrinally requires all of this FDA regulations, we're actually never storing blood, we're transporting it. We transport it for the life of its expiration. And their ask to us was essentially, you have to make it worth our while. So they have a quota that they'll shy away from giving you numbers on, but it's going to be somewhere around 150 units of low titer O blood that they sent to the combatant commands. And like I have a 540 person battalion, which is in actuality probably 400 people, and half of them are gone. I can't meet that quota, but what I can do is make it worth their while. So I need to give them enough blood that it is worth their time to spend their time with my unit and not at some other unit collecting blood. And I want my 6 units. So our goal, as we set up, was kind of about 50 donors per month, which we had now set up monthly blood donations. And they're on the 3rd Thursday of every month. So this is sort of falling in our battle rhythm. And we expect that of the 50 donors, about 40 are going to be O-type, and almost all of them are going to be low titer. And so that's what we did. And knowing that we would have to have maximum support, 50 is actually a fairly high number. Second Battalion First Group has experience doing blood drives. We do it at the team levels pretty frequently, pre-deployment, to either retiter or type new arrivals. Usually this was run by the team medic coordinating directly with the donation center. And the flyers go up in the battalion, so there is actually like battalion support for it. People see the flyers, they see the blood being drawn, and they go and they donate because we're good people by and large. Recognizing that we needed maximum participation, we took ownership of all blood draws up at the battalion level, which gave us the opportunity to then, like as battalion staff, at every commanding staff every week, the next donation event is briefed, and we did schedule it, so it's always going to be the 3rd Thursday of every month.
at every training meeting. The next donation is briefed. And then I sat down with our commander and our sergeant major, who were very supportive of this, and we agreed that for every donor, 4-day pass, and for anybody who maximizes donation, which is every other month, at the end of the year, that's an AAM. We're also able to, and this speaks to the question that was asked to the Sergeant Major of the Army this morning, the ASPVC types all blood that it gets, and it titers all O blood that it gets. So if you're donating blood, they will type and titer. And that doesn't cost me money. It costs the Army money because the ASPVC is the Army. But it doesn't cost me money. So every in-processing person gets typed and titered. I can't make them donate, but I can make them get typed and titered. Recognizing now that we had cold blood or would be able to have cold blood, and that the regulations, there's a bunch of guidance on giving blood, but none of it specifically speaks to blood in CONUS, where FDA regulations and certain state codes apply, nested within the SOCOM guidance for solo and in the 2 JTS guidelines, which is whole blood transfusion and pre-hospital blood transfusion. We wrote a protocol, the cold blood protocol. I'm proud of cold because it's cold stored O-type, low titer donor blood. That took me like 2 days. It's still evolving. It's got my signature block on it as an Italian surgeon because I know it's going to evolve and change as we run into different obstacles. As of the third Thursday of last month, which was April 24th, we've given 95 units to the ASPVC. That's type non-specific. They've given us 21 units of FDA-approved cold blood. So again, it's cold stored O-type, low titer donor blood. We've done 10 training missions with blood, including haloing blood in Yuma, flying commercial with blood, and there's 4 units out now at Yakima. Additionally, these training scars that Justin was talking about, we've been able to make the 18 Deltas in my battalion much more comfortable with cold stored whole blood. And I'll tell you, as an ER doctor before we got into this, I don't know that I could have told you how long it can be out of the cooler or what temperature it can reach before it's no longer good. That's something I'm intimately familiar with now, and my 18 Deltas are too, because they have to prove it every time they draw blood. They have to prove familiarity with cold blood. They have to prove that they have fluid warmers. They have to have TXA and calcium with them. They have to prove that they know my protocol. And so I now feel very confident in my 18 Delta's ability to deliver cold stored whole blood to casualties at POI in CONUS. So now June will be the 6-month mark for this program. We'll sit down with the ASPVC soon and decide whether the way ahead is exploration, continuation, or expansion. Based on the numbers I've seen and our constant coordination with them, I don't think it's going to be expired. And so the real question is, where do we go from here, and what is sort of the way ahead? Does this program belong at the battalion level, where it's been fairly easy for us to communicate both with battalion staff to raise awareness and with company and team level medics to make sure that there's support for it and to issue out blood? Or does it belong at the group level, where we do get more donors and more participants, but also as I expand it to the group level, 6 units is probably not enough. And so right-sizing that and figuring out what is still beneficial to the ASPVC and the unit. And then also, as we figure out the way ahead, is this something that should get larger through SOF? Or is this something that, because it's working at JBLM, should be installation expanded rather than coming up through the SOF channels? And I don't know the answer to that. I do know that if you look at recreating this program elsewhere, the proximity to a blood donation center is key. There's 20 ASPVCs in the world. 4 of them are OCONUS, at Tripler in Guam, in Okinawa, and 1 in Europe, which is Germany. And then the rest are scattered throughout the United States, but not co-located necessarily with SOF commands. So this program becomes much more difficult if you're not co-located with an ASPVC. Other things that are critical to our way ahead: we throw away 6 units of blood every month. That hurts my feelings, and it will only get worse if we expand the program. So if my battalion takes and throws away 6 units every month, and we expand it to the group, you could expect us to throw away 24 to 36 units of blood every month. I don't think that's tenable. There are ways around it. Civilian programs, even adjacent to Madigan, have the ability to sign out blood to their EMS through coolers that register and maintain temperature logs, and they put a sticker on it, and then they take it back prior to expiration. That's probably the way ahead for us. That was a bridge too far for the lab at the time, but I think as we move forward, that's probably the answer for most of our blood. Some of it will get jumped out of planes or fly up a mountain, and it will get wasted. But most of it could go back to the MTF. It's not the answer for the combatant command, which is what the ASPVC cares about. Also, Madigan is still on component therapy. So what do they do with whole blood I turn in? They don't have a protocol presently for giving me whole blood. So I think the answer to this is not just a unit answer, and it's not even just a donation center answer, but this is probably something innovative between the MTF, the unit, and the donation center. And hopefully that's in the near future. In the LISCO, it wouldn't be SOMA if somebody didn't say LISCO. So what does this mean to LISCO? This policy is not meant for LISCO. This policy is meant for putting blood at the point of injury in CONUS for training. But what it has done, inarguably, is increased my medic's knowledge of how to use cold stored whole blood, as opposed to what has been kind of like just a hip pocket answer, like Rolo, I draw it off that guy, I go to that guy, everything's fine. So now my medics know how to cold store whole blood, and in the absence of guidance and where it is difficult to get blood sent from the ASPVC, and where there is no Roll 2 or Roll 3 to pick it up from, they know what the right answer for cold stored blood is. And I think having that in their pocket is probably a benefit, no matter how you move forward. So I think that's probably it for us. These are my references. I'm gonna move through them quick just so I can do one more plug, not for me, but for Dr. Leonard. This is an amazing case of a guy on a first troop range who sucked Madigan's blood supply completely down to zero, and is a really neat case for several reasons.
That's it for today's podcast. Make sure to go to our website, www.prolongedfieldcare.org. Check out our free downloads and a ton of other helpful information. Grab a bag of our fresh roasted PFC coffee, links in the description below, and stay on the bleeding edge of combat and austere medicine. This is Dennis for the PFC podcast. Out.